Before I get started, y'all probably know me by Susan Moore. I worked over in Two Heart for 35 years, and then last year I went over to E-Link, but I still am doing balloon pump classes for now. So my question is, you all are, you have your specialty, and I am assuming that you probably don't want any anatomy and physiology. And just work more with the balloon. Is that correct? Okay. So this slide, we can just go through a lot of it. And then start in on balloon pump stuff. So I'm going to be walking back and forth, because
you don't have no clicker.
It's okay. You know what? I've been in worse situations, so it's okay. We always seem to improvise something. So we're just gonna go through. Y'all know about how the heart works and what happens when we have a problem, and of course, with balloon pump insertion, we want to increase the supply for the end, and that happens during balloon inflation and decreased demand, and that happens during the deflation, and we'll talk more about that. And you don't have to worry about that, but you do have to worry about when you're transporting the possibility of the catheter movement. So excuse me, approximately 1 to 2 centimeters distal to the left subclavian artery between the second and third intercostal, and there is a picture of it. And we'll talk more about how you can tell if it's moved or not. So inflation, it occurs at diastole. And there's a picture of your deflation, and it occurs at endodiastole. It looks sort of like a long, skinny hot dog. And so when we have a balloon pump, we have the blood pressure, we have the systolic, the diastolic, the MAP, which is really important. We go by the MAP more than anything else. And then we have the diastolic augmentation. How much is the balloon helping the heart as the diastolic augmentation is working? And the higher it is, it's not necessarily better. If you do not get much augmentation, it's still working, because every time that balloon inflates, you're getting extra blood in the coronary arteries. So yeah, we like to have it as good as we can. We time it as good as we can. No one is ever textbook picture like I'm going to show you in here. But just remember, as long as you've got it timed properly, then you'll be okay. And seeing being as you're going to be transporting, and you're probably going to have a lot of movement, there's a easy way to show whether it's timing well or not. And these pumps are so good now that you rarely have to take it off auto. There have been a couple cases that in my long career that I have, but most of the time the auto works really well. So some problems that you can have that does affect the diastolic augmentation is the heart rate. And we used to think a long time ago, if your heart rate was really high, 150, 200, we just put it on 2 to 1 instead of 1 to 1. Well, yeah, the numbers did look better, but that was not achieving anything. So if you are on 1-to-1, you need to leave it on 1-to-1. It times well, you just need to work on getting the heart rate down. It can affect your stroke volume and your MAP, increase your SVR. If the balloon catheter is not unfolded properly or not in the sheath, that can really cause problems, and that will happen in the cath lab. That rarely happens, so that's really not too much to worry about. Your low helium, after the low helium light comes on, you still have 12 refills in 24 hours. So that's not anything for you guys to worry about either, but you want to, when you arrive to wherever you're going, you want to let people know that your helium light's on. Timing is important, and the old machines, every time the heart rate increased by 10 or decreased by 10, we'd have to retime it. But we don't have to do that anymore because it pretty much times itself depending on what. One of the problems that can happen, but rarely does happen, I think I've seen 1 or 2 balloon pump leaks in my time, and a kink in the catheter is the most common, and that's because the person's moving their leg up. And you can have a kink right here, and it can make it alarm more. And then the position, of course, of the balloon pump catheter. And anytime you have any questions, please stop me. Very informal, as you probably can already tell. So why do we put in balloon pumps? For the ventricular failure. Big one is cardiogenic shock. And you may be thinking, well, you know, we have the Impella these days. Why use the balloon pump over the Impella? And you know, it's really physician preference. The Impella does work differently, totally differently from the balloon pump. And a lot of it is physician preference and what the doctors are used to.
What is, I'm relatively new, what is the Impella?
The Impella is a machine that goes into the heart and down, there's a little motor with it turns and just very, very fast, and it goes past into the left ventricle, and it removes fluid. Okay. And it turns so fast, it removes fluid, and it helps the heart a lot if they're in cardiogenic shock or if their ejection fractions are low. It's really amazing how fast it turns. I mean, just the RPMs are amazing on it. But it's rather delicate because you have to have it across the valve into the left ventricle. If it moves back any, it has to be repositioned. So you really can't move the patient around very much.
Which is probably why the balloon pump would be the preference of the physician.
Well, yeah. If they have ventricular failure or heart failure, really bad heart failure, high risk PCI, a lot of times some of the physicians will choose to use an Impella instead of a balloon pump. But it's a lot quicker to use with the balloon pump. And I'd say physicians are familiar with balloon pump. Most of them that are invasive can put in a balloon pump, you know, with their eyes closed. But it's a bigger deal, and there's not as many doctors at home who can put an Impella in. Okay. You know how it is. It was the same way with balloon pumps when they first came out. The patient had to practically be dead before they put a balloon pump in. And then the Impella came along. It's sort of the same way, but now they're getting more familiar with the Impellas and getting more comfortable. So they are putting them in before the patient is just in full-blown cardiogenic shock, and they have saved a lot of people. Okay, so mechanical complications due to the MI, maybe they've blown a valve or something like that. And one thing that is rather common here at Cone is for people who need open heart surgery and they're high risk, they'll put a balloon pump in like 24 hours before they go to surgery. And studies have shown that if they do that, the survival rate is a whole lot better, to let the heart rest some before they have their surgery. And some patients need the balloon pump during bypass and afterwards. And also failed angioplasty and valvuloplasty. Sometimes the decision has to be made, patient has a really low ejection fraction and they put the balloon pump in. Well, the heart's loving it, but it can't stay in forever. So the decision has to be made, what are we gonna do? Is the ejection fraction gonna really improve that much? Our medication is going to improve it. The balloon pump have to come out after several days. There's your contraindications. Of course, your aortic insufficiency, an aneurysm, or your aortic iliac disease, PVD. I tell you a scenario we had where a patient came from a place in Virginia, a hospital in Virginia, which I'm sure you all know. In fact, you guys had brought, this has been a few years ago, you guys had brought us a patient with, they had put a balloon pump in at that hospital, and the next morning everybody gets a daily chest x-ray, and on that chest x-ray they showed an aneurysm, and here was this balloon going well, we all just, just wigged out because it's gonna blow in a second. So we got it out right away. But I've always wondered, how did they put it in the first place? Did they not see it?
I know which one you're talking about, and I'm pretty sure that patient had 2 balloon pumps placed, because the whole reason we ended up getting the fiber optic device was because up there they were using it. We weren't here. Okay. So the crew went up there to get the patient, take our pump, go get the patient. Well, the problem was when they got to the bedside, they were using fiber optic. Well, they had let the other one, the regular pressure line, clot off. Okay. So remember now, you can't. It's not going to work.
Yeah.
Okay. So they had to call the cardiologist in, who was not happy at all. Because they didn't care if it clotted off. They had to let the pressure bag go and all that stuff.
Right.
And so he had to come in, and they said, and Luke, he said they rewired it. They went in through the clot, pulled the old one out.
Oh gosh.
Put a new one in or something. They did a little trick, and then that's how they brought them down. And then we ended up getting those, so they didn't have to have that problem anymore. So.
Well, the person survived, so, but that was scary. So here are the balloon pump sizes. And here at Cone, we only have 34 cc and a 40 cc. And the size is really important because of your height. So if you're they say 5'2" or less, you really should use the 34. But if you're taller than that, you can use the 40 cc. And even with people that are short, they have put 40 cc's in. That is the most common one. We don't even own 25s or 50s. So the balloon insertion only takes a few minutes, and it can be done in the room or in the cath lab, but the doctors here prefer to do it in the cath lab because they can see a whole lot better. And so we'll turn the balloon pump on now. And the hardest thing to do is find how to turn it on. And it's hidden for a reason. visitors like to mess with the machinery. I don't know why. They do. In fact, I was making camera rounds the other day, and the IV pump went off, and one of the guys that was in the room, one of the visitors, just hit the silence button, and you know, if that had been dopamine or Levophed or something like that, and the patient really needed it, something bad could have happened. So I had to tell on him. I had to call the nurse and tell on him. So we've got the trainer in, but when you don't have the trainer in, you'll have your ECG leads hooked up to the patient, and you'll probably have 2 sets because you'll have them on your machine. And then you have your arterial pressure, and this one is for the trainer right here. So you'll have your setup, and you all know what all this stuff looks like. I don't have to go over this. And you have to zero it initially. If it's non-invasive, if it's fiber optic, it zeroes itself. And
It's the best.
yes, and you know, Cone hasn't had the fiber optics too long, but thank goodness we have them now. So,
Alaman's been using it for a while.
yes, they were before Cone was.
Right.
And you would zero it, and the little 3 zeros would appear. And we'll put it back to normal, and hit your start button. And I want to open the menus and make sure that my augmentation was all the way to max. It's auto-filling, and the first time it takes a little longer because it fills twice. And there you go. Easy peasy. So, where you have your trigger here, and your trigger is always going to be your ECG. However, excuse me, let's say a patient pulls his lead off. It'll automatically go to pressure and trigger off of pressure, and that's really nice. So you figure out why you don't have ECG anymore. You fix it, go back to trigger. That is the best. Your pacer, you have pacer B, AV, and pacer A. Really, you do not want to use those at all. And the reason is, if your patient is pacing and all of a sudden has his own rate, it's not going to work. So, it's better to always trigger an ECG. And then you have each internal. In the old days, when the patient arrested, we thought we had to put it in internal, and it just sort of flutters. The patient codes these days, forget about the balloon pump. Just code your patient. And it won't hurt a thing. And actually, by doing the CPR, you're going to generate a little bit of pressure on here. The way we do CPR these days, generate pressure. So you don't even have to worry about doing anything to the balloon pump if your patient codes. And then you have your auto and semi-auto. Well, you want to leave it in auto unless you see a problem with the timing. And 99.9% of the time, you're not going to see a problem with the timing. But if you do put it on semi-auto, then you have to oh, it's locked. It's locked screen. Stand by, put it on semi-auto, and then your timing is right here. Your inflation and deflation. Now, this is probably a good time to talk about timing. They call this your glow worm, the little blue. as long as it starts right at the dichrotic notch and ends before the upstroke of the next beat, that's the best you can do with your timing. The nurses, they usually like to run a strip, you know, and analyze it and that kind of thing, and that's fine. But the quickie is always to do this. Let's see, let's see if we can do something. Okay. Can you see where the inflation is now? Yeah. I'll just be extreme so you guys can see. So you actually would not be doing any favors whatsoever. Now you're way below the dichrotic notch. And then the deflation, let's put it back to where it should be. And then we'll do the deflation. So you have quite a bit ways there that actually these are off extreme. They can cause damage. It will not help your patient. Well, that one, see, that one won't do anymore. So we are not dummies by any means, but they call this dummy proof. Let me put it back on auto. Your augmentation, you want the balloon all the way up to inflate and deflate. If you have that one of the my mind's just gone blank, where your patient is moving and it's got
Kink. A kink in it.
yes, has a kink in it. You can deflate this, maybe one or two, and that'll help it. It won't hurt the patient, but it might not say kink. The kinking might be better. That's why we put a lot of patients on long leg immobilizers too, so they can't bend their leg. And then that's your timing. It says preferences. Our speed is always 25 millimeters per second. Our balloon waveform, you can have on or off. But the balloon waveform, I'll show it to you again, can help you with how the overall picture is looking. And you got your EKG markers, that can be off. You really don't need those. Your balloon inflation is on. Your brightness depends on what you like. Then we have a reference line that you can, if you want to look at something, you can go up and down, measure. And you can do this while it's pumping too.